Hey, it's Dr. Centeno. Regrettably, still no power at my place, so I'm out at a place I could get a 5G signal. So hopefully this works. May not work as well as being at home with a broadband internet connection, but I'm going to give it a shot. So again, just so that everyone knows, in Colorado, we've had a bunch of really high winds, a little different than our normal Chinook winds that come from the mountains and can get pretty intense at times. These were having something to do with mixing with the jet stream, and the winds were very inconsistent and very powerful. So we've had power outages off and on all weekend. And then on top of that, still no power at my place. And obviously there's lots and lots of people without power. So I am out in my car trying to find a good place to get a 5G signal, and wanted to try to answer questions as best I could today on craniocervical instability. So rather than my normal give a presentation or interview somebody, I'm just doing an AMA or Ask Me Anything so that people can get a chance to ask questions. So that's what I'll be doing today for as long as you've got questions over the next half hour or hour. And I will try to make this work via hotspotting off my cell phone, which is what I'm doing right now. So let's start with Casey's question here. What patient history helps you distinguish whether you decide to treat a nerve versus a dysfunctional joint? As far as patient history is concerned, nerves tend to be a little bit different. Nerve pain can be described as nervy. Now, sometimes not, right? Sometimes you can get, for instance, irritated occipital nerves back here, and those will just give you a headache, and it doesn't really have to have a nervy or burning quality, which is what you normally associate with nerves. Now, that can overlap, for example, with upper cervical facet joint pain, which can also refer pain to the same areas. And then the two can mix together pretty frequently. So we'll frequently see that there's an irritated occipital nerve back here in someone who has craniocervical instability, for example. And then on top of that, they'll also have pain coming from a joint that is referring to the head as well. So in that case, we treat both. So it's not so easy to do via history. Now, exam, it's a little easier to do. So for example, I can put pressure over the greater occipital nerve or the lesser occipital nerve and easily determine if pressure there changes that headache. I can also put pressure specifically over the 0-1 facet joint, the 1-2 facet joint, the 2-3 facet joint, and see if those are tender. So an exam, it's a lot easier to figure out than it is just by patient history. The problem with patient history is going to be you're going to get a lot of overlapping symptoms. Julianne, thanks so much for all your service. Thank you. Just to remind everyone, I'm just sitting in my car here. We don't have power at my place. The clinic has had power. No power interruptions at all at the clinic because the clinic is far enough away from the mountains, but all the properties that are closer to the mountains here in Colorado in the Front Range have had power intermittently, or some people have had no power for 4 or 5 days. So because of that, I'm out here sitting in my car trying to find a 5G signal. So hopefully all this works, but I did want to do at least an AMA today to answer questions. JS, why do I have symptoms when I do cardio exercise? Neck muscle tension, scalp hurts, feel like a headache coming on, and sinus pressure. Is that CCI symptoms? You know, it could be CCI symptoms. It doesn't have to be. Now, normally if it's coming from the neck, that's an upper cervical problem. So upper cervical spine is what usually refers to the head. So if you've got headache with working out, we can be fairly certain that it's probably coming from the upper neck. Then the next question would be, Is it instability in the upper neck, which would be craniocervical instability, or is it craniocervical syndrome, which would just be a structure in the upper neck without instability causing that headache? Now, I would agree that if exercise makes it worse, then you're going to put craniocervical instability higher up on the differential diagnosis. Having said that, you can also have really bad posture and get much more overload of this area, the upper cervical spine, with exercise. So based on that, there's really no hard and fast rule that says that if exercise makes it worse, it's CCI, but it does make you think that it could be CCI. So obviously you then want to get movement-based imaging to make sure you don't have CCI, see a CCI expert who can do an upper cervical exam and easily determine, yes, this looks upper cervical, yes or no. Oh, yeah, I didn't know that the Northwest had been hit hard. Yeah, we've just been having some strange wind patterns here. The winds are dead now, so the winds aren't really a problem anymore. But XL Energy is taking its sweet time turning back on the power. So that's what we've been dealing with. Would you caution against, and this is Wiggy, would you caution against trying trigger point injections in your neck if you suspect cervical instability? You don't really need trigger point injections. The research has shown that trigger point dry needling will do just as well. So I wouldn't really get a trigger point injection these days. I think that's probably adding more risk than you need. I would get trigger point dry needling, which can be done at a lot of different physical therapy offices around the country. Now, is that a problem with craniocervical instability? No. Having said that, we do have CCI patients that need that tightness that comes with trigger points to provide stability. So once you get rid of the trigger points, then the CCI symptoms tend to magnify or go up. So important to realize that at the end of the day, not a problem to get trigger point dry needling or trigger point injections, although trigger point injections are kind of old-fashioned 1960s, 1970s, 1980s stuff. Trigger point dry needling would be the more modern form. But just realize that if your symptoms increase after that, that could be pathognomonic for craniocervical instability, because a lot of those patients really need that tightness. Hey, Dr. Centeno, why do I flare when I don't eat for too many hours, or don't eat the right foods, or don't eat enough? I'm trying to lose weight, but flare if I eat it in a deficit of any kind. You know, I don't know. Let me try to see if I can change the light situation here. You know, I don't know. Certainly, sugar instability is a big problem. And as part of a metabolic syndrome. So that sounds more like metabolic syndrome. Metabolic syndrome is when you have blood sugar instability. That's worse when you're not exercising. It's better when you're exercising, and it's very genetic. And it's also associated with being heavier, high blood pressure, abnormal blood lipids, etc. So my sense would be it would be more related to that, stoking inflammation, because we know that metabolic syndrome and blood sugar instability can stoke inflammation, and not really having much to do with craniocervical instability directly. D07, have you treated patients with CCI and Chiari type 1 that have not had surgery for the Chiari and seen improvement in neurologic and autonomic symptoms? Yes, a large percentage of our patient population would have some sort of Chiari diagnosis. More commonly, Chiari 0, maybe 2/3 of our patient with Chiari 0, about 1/3 with Chiari 1. Again, Chiari by itself generally does not cause symptoms. I'm going to say that again because it's a critical component that I think a lot of Chiari patients get confused by. Chiari by itself, a 0 or a 1, is not a symptom causer. I'm going to say it a third time. Chiari 0, Chiari 1 by itself doesn't cause symptoms. How do we know that? We know that because we have studies that show there are people walking around with Chiari 0 and Chiari 1 that have no symptoms at all. So what causes symptoms in patients with Chiari is something else. So symptoms come from Chiari plus something else. In this case, the something else could be craniocervical instability, which means you treat the craniocervical instability, meaning Chiari is just a normal anatomical variant in its 0 and 1 forms, and you don't need to do anything for it if you don't have other issues that can cause symptoms with Chiari. So again, if you've got Chiari 1 and symptoms, the focus is treat what's causing the symptoms, which if you've got CCI would be the CCI, not the Chiari. Vero A, good morning, Dr. Centeno. Thank you for taking time to answer our questions despite the weather. What could be having a Pannus, a CXA 136, and neutral supine MRI and inflammation 001 indicate? Well, CXA 136 is normal, so that's not a concern at all. With regard to a Pannus can indicate that there's been too much motion in the upper cervical spine. So too much motion in the upper cervical spine. I'm trying to get the light right here, guys. Sorry. Hard to do in a car. Too much motion in the upper cervical spine can cause swelling, which can cause the bursa up there to swell, which can cause a Pannus. And then inflammation in the 0-1 joint. If you had a CCI type 1, or even possibly a CCI type 2, then that can cause inflammation in the 0-1 joint. So those are just secondary bits of information, not primary bits of information, or circumstantial evidence, if you will, that there could be a problem in the upper cervical spine or craniocervical instability. Next question is Kevin. Hi, doctor. When I wake up in the morning, I feel fine. After a couple of hours, I start feeling off balance at times. Never was diagnosed with CCI nor AAI. However, I do have clicking and gravel sound. I've had treatment with Prolo under fluoroscope. I'm actually going tomorrow for another round. Yeah, so if you're feeling off balance, Kevin, from your neck, then it's probably the upper neck. And that's the best I can tell you because I don't really know too much about your clinical condition. Sounds like you're getting some prolotherapy done. That's great. Prolotherapy can be very helpful for generalized neck instability and helpful for neck pain patients. But my sense would be the next step is to try to rule in or out craniocervical instability. If you rule it out with movement-based imaging, then your next steps would be to say, is this coming from my upper neck? Which means you might need something more than Prolo, right? Simple Prolo is not really going to target, for instance, upper neck facet joints, upper neck nerves that might be irritated. It's just going to kind of focus on the midline ligaments and tightening those down. Thank you, Kevin. I'll say it again for those of you that have joined us later. Big wind in Colorado this last couple of days has caused power to get shut off, including our power, not at the clinic, but at my home. And if we add on top of that, the fact that Xcel Energy is very slow to get the power turned back on, I'm out here in my car, sitting in a Whole Foods parking lot trying to get a 5G signal so I can answer some questions today. Submitted advanced by Sherry Scott. Do you know of any chiropractors that you would recommend in South Florida? No one in South Florida comes to mind, but I can certainly recommend Julie Hunt. Julie is in the Clearwater, Florida area. I think she's great. I've known her for many, many years as far as being an upper cervical chiropractor. Blessed, what does it mean if symptoms are worse after posterior PRP received from your clinic? Yeah, so I don't know enough clinically to answer this question about what's going on with you. If you have a type of craniocervical instability that requires internal ligament treatment, which would be any of the type 1s or type 2 or a type 3B CCI, then you may just need to move to PICL, but I don't have enough information. Patients can get significant flare-ups after any kind of injection, especially if they're centrally sensitized, but I don't know enough about your clinical history to answer that particular question. Blessed, what's the link between ME-CSF and CCI? ME-CFF, or sorry, ME chronic fatigue syndrome, myalgic encephalitis, or is basically a black box. And in that black box diagnosis, there's lots of different things going on. There can be patients who may have, there's some recent research on mitochondrial issues. There are probably quite a few craniocervical instability patients that are inadvertently put into that box. So it's not really a specific diagnosis for us to say that everyone in that box of a diagnosis has the same thing. It's probably a pretty heterogeneous group. Within that group are craniocervical instability patients. I know because we see them all the time and we treat them and they do well. So just realize that that's not a specific diagnosis. And because it's not a specific diagnosis, there's going to be a lot of different types of more specific diagnoses within that, that big box called ME-CFS. D07 are certain CCI types more successful for PICL. You know, I've studied that pretty extensively at this point, and the answer is no. There aren't any more successful CCI types. I can say, though, that if you've got a type 3 CCI, you do not need a PICL procedure. That I can say pretty clearly. And I can also say that if you've got any other type of CCI, type, for instance, 1A, 1C, 2A, 2B, 3B, then a PICL procedure would be what you need, because those are problems involving internal ligaments. Julian, totally agree that tightness helps, because when I've been in PT exercises or TENS or relaxing techniques make me feel worse. Yeah, Julian, so that's a pretty common thing among craniocervical instability patients. Basically, they find that that muscular spasm or tightness is very, very helpful for them. And it helps to provide stability, which is critical. How do I convince the surgeon that CCI is more of an issue than the Chiari malformation that he wants to do surgery on, the only static imaging, and aren't aware of the benefit of dynamic imaging? Don't know, Cassidy. You got to get with doctors that know what's going on. And if you've got a surgeon that doesn't understand craniocervical instability that wants to decompress your Chiari, I'd say find a new surgeon, meaning that most of the surgeons in this space that are very experienced understand that those two are comorbid. Guys, I'm going to try to go ahead and change my orientation here because I'm getting a lot of forward light, but let me finish the answer to this question. So the only answer I can have for your KCN is try to find a surgeon that knows which way is up. And if you're seeing a surgeon who doesn't understand that CCI and Chiari are comorbid, then that's not the right surgeon. And that's because I see patients all the time go down this very, very crazy rabbit hole. And that crazy rabbit hole is they will get their Chiari decompressed, which they probably, frankly, don't need to do, because their Chiari is not causing problems. It's the CCI plus the Chiari. Then their CCI gets worse because they're destabilized. And then they're all scratching their head saying, I wonder why the Chiari got worse. Well, the Chiari got worse very simply because at the end of the day, it wasn't the Chiari causing symptoms, and you made the CCI worse. So I would very strongly recommend you find another surgeon. Hey guys, I'm going to try to switch my orientation here. So this may be a little bit Let's see if I can do this here. I may not be able to do that while sitting in the car. Okay, looks like I'm gonna have to stick with what I got here, guys. Okay, tried blood chiropractic assessment, and it made my symptoms worse. It made my symptoms worse. What can I do to relieve my dizziness and head pain before a PICL injections if I get approved as a candidate? Maggie, I would have to know your clinical history to understand how to advise you there, which I clearly don't know. So I can't give you that advice. So not quite sure what to say there. Does Dr. Rosa have specialty imaging that DMX and a regular MRI don't offer? He does. He has a specialized upright MRI. For those of you who don't know, Dr. Rosa is an upper cervical chiropractor in upstate New York. And being an upper cervical chiropractor in upstate New York, he very early decided to take a very acute interest in upper cervical imaging. And as part of that journey, he got a phonar, or an upper cervical or upright MRI, in his office. And very early on, he worked with the phonar people to look at cerebrospinal fluid flow dynamics and how that was affecting his patient population, including CCI patients. So Dr. Rosa offers really the only CSF flow studies that I'm aware of in the world that focus on CCI and upper cervical conditions, because of his experience of being an upper cervical chiropractor. So he offers some extremely unique imaging in upstate New York. Does the muscle guarding need to be remedied for the ligament tightening from PICL to fully repair the instability? With PICL1, the symptoms got a lot better until the muscle tightness was released a bit. Yeah, if you're finding you still need muscle guarding, then a couple of things are probably true. There's still quite a bit of instability. So from the instability standpoint, that may need more work with regard to additional PICL procedures, or there's still quite a bit of muscle or deep segmental muscle atrophy where you're not getting good stability out of the deep muscles that are supposed to stabilize segment on segment. And then what happens then is that the large muscles take over. So I'd have to know more about your clinical condition to answer that question. But for most patients, it would be one of those two. I'm from Denmark, Scandinavia. Do you offer online consultation? Yeah, we only exclusively do online telehealth, simply because that allows us to try to see whether or not it's appropriate for the patient to travel to get treated. Because at the end of the day, we want to make sure that if someone makes the trip out here to Colorado, that we can help, or that we think we can help. And it would be far easier, obviously, just to accept everybody and have them all come out here, but that's not appropriate. So we do actually first a pre-screen, And the pre-screen is done by me personally. I do all of them to try to make sure that that person has craniocervical instability. And then from there, they get greenlit for telehealth. And the telehealth obviously is agnostic to where the patient lives. And then if those two things are checked, meaning the pre-screen looks like CCI, the telehealth looks like CCI, and we can help, then we allow the person to come out here. So yes, we do telehealth extensively. Cardfell, I'm not going to engage there. That's a little bit of trolling behavior. So I'm not going to engage with that. I did have a digital scan, have CCI and AAI. Yeah, Maggie, again, I still don't know enough about your clinical history to answer your question. There's more to just saying you've got CCI and AAI than in order to answer your question. So I can't answer your question without clinical history. I had a lower neck ultrasound, guided dextrose prolo, C4 to C7 in the suboccipitals and skull area. Afterwards, I felt dizzy and lightheaded. Then my tongue, jaw froze, went mildly numb for a couple of hours. Then I had tachycardia. It was okay by the evening. Lidocaine gotten into a nerve. Yeah, Vera, this is one of the reasons why we don't recommend these kinds of procedures, meaning, when you're using ultrasound, it's better than blind, but you're not making 100% sure that you are avoiding getting into a blood vessel or a nerve. So ultrasound is very, very technique dependent, and it's very, very user dependent. So while the most advanced users in the country can probably use ultrasound to stay away from blood vessels, for example, 90% of ultrasound users who are physicians wouldn't be able to do that. So that's why we only use ultrasound for the more superficial stuff. And for anything deep, we use C-arm fluoroscopy with digital subtraction angiography, where you can easily tell, for instance, if you're getting into a blood vessel, you can tell if you're getting into a nerve, etc. So again, ultrasound only is better than blind prolotherapy, but it's still not standard of care. Standard of care would be using both ultrasound and fluoroscopy with digital subtraction angiography in this particular patient population. Cartwell, PICL in Europe, some doctor. Yeah, there are no physicians in Europe that are performing PICL or have been trained by me to perform the PICL, or I would send a PICL patient to. Michelle Wilson, parathyroid surgery, March 2023, issue with neck and C1, C2 since, diagnosed with POTS and MCAS. After that surgery, couch-bound since, what's possibility? Something in the neck causing this. I get horrible electrical heart pounding. Yeah, Michelle, there's certainly, you can get worked up for all of that. It would be movement-based imaging focused on the upper cervical spine. So that would either be a DMX or upright MRI with flexion extension. That would certainly be the next step for most patients. You would also see an expert in CCI who can try to determine if this looks like all of these symptoms are coming from the upper neck. Lisa, I had BMC on 11/25, facet 03, and lumbar spine planned for late January, and PICL2 in April. I know the spacing between PICLs has not been optimal, but have been in a race with hEDS. Not sure, Lisa, if there's a question there. From a treatment standpoint, you'd probably want to put at least 3 or 4 months between those bone marrow injections, but I don't see a question, so I'm just going to kind of give you some general advice there. D07, I can do all laser clock movements, but when I do 2 to 4 doesn't feel smooth, more tight in the upper neck and occipital region. Would that indicate anything? I have type 2B CCI for reference. Yeah, that certainly could indicate that the CCI is causing you problems, and that's something you'd want to get checked out for. Meaning there's one thing to get a DMX and to get some imaging done, but the next thing well beyond that would be a hands-on exam by a CCI expert who can say, here's what I think is going on and here's why that's happening. Cartfell, is CCI healing possible? It is, based on the, I don't know, how many patients at this point, let's say 2,500 PICL procedures that our clinic has performed. I would say we have lots of patients who are in that category where their symptoms have gone away, their DMXs have normalized, or their function has dramatically improved so that they don't feel the need to proceed with surgery. Lisa, since BMC, I can't stay warm despite good sleep and nutrition and a 72-degree home. Is it normal post-BMC or CCI anomic vagus response? I've had this problem since CCI, but now worse. Lisa, I don't know enough about your clinical history to answer that specific question. Blessed, how far are you booked out for EPICL? We're in a pretty interesting spot right now. Normally I would say March or April, but I just opened another PICL slot that started in mid-December, I believe. So we have a few slots open right now simply because I opened more slots, and that's unusual for my particular schedule. So just FYI on that. So the answer would be right now a little sooner than normal. JS, is there a procedure to fix vertebral artery oscillating against the medulla causing debilitating neurosymptoms? This is looked off unless a BAS contrast MRI is done. I'm not quite sure what that means, but I think what you're postulating is that your vertebral artery is causing problems. That would be very uncommon. So the first thing I would say is that the likelihood that that's happening is maybe only 1 in 100. So it's important to understand that that's probably not what's causing your symptoms, just based on the odds. Then the second thing would be I would need to know much more clinical information. So for example, is there something else involved that's comorbid like craniocervical instability, etc.? Maggie, yeah, Maggie, I think I told you before, these are all meaningless pieces of information to me. They don't indicate anything. So what Maggie is asking, I think she's copying and pasting a DMX result here that is using basically diagnostic codes that are meaningless when it comes to trying to figure out if Maggie has symptomatic craniocervical instability. So using traditional CPT or ICD-10 diagnostic codes, as the case here, doesn't get us to determining whether or not you've got craniocervical instability causing your problems. There just isn't enough information here, Maggie, and these are super general codes that don't mean a lot. Most of this information you couldn't get from a DMX, meaning you can't diagnose a cervical facet syndrome via a DMX. So this is all nonsensical information. Blessed, if a person had a procedure with your clinic with a different doc, can they transfer care to you rather? If so, would a telemedicine appointment be needed? Yes, that is possible to do. Maggie, as I told you before, I think you put some of this stuff on Reddit and sent me a private message. The information you provided doesn't give me any data on what's wrong with you with regard to your CCI type. Hence, I can't give you any sense of how most patients would respond to things like PRP, Prolotherapy, posterior injections, PICL, EPICL, all of that good stuff. Blessed, does Dr. Rosa also do flexion and extension with his upright MRI? He does. Abby the Kid, have you ever seen cases of mild CCI AMA kind of instability that doesn't show up on upright X-ray or supine flexion extension MRI, which are symptomatic and vice versa? We have. Now, I wouldn't expect to see upright X-ray to show craniocervical instability. A DMX might, and obviously upright MRI with flexion extension might show craniocervical instability. But when it comes to what you've listed, there would be large gaps, meaning someone could have craniocervical instability and it wouldn't show up on what you've listed. Would sole symptom of heavy head be indicative of CCI or more functional instability, motor control atrophy? I have hEDS and noticed that bouncy floor feeling has improved 70% with laser exercise. A sole symptom of heavy head wouldn't necessarily indicate craniocervical instability, no. You would need movement-based imaging and a hands-on exam to get to craniocervical instability or not. So just a heavy head by itself wouldn't really get us there. We'd need more information than that. Now, a heavy head can come from lots of things, right? A heavy head can come from a forward head posture. That forward head posture can cause the head to feel heavier because it's not centered correctly. You can also get a heavy head because the upper cervical stabilizing muscles are offline. You get a heavy head because the upper neck joints are irritated. You get a heavy head because there's craniocervical instability. Vero, how many injection treatments are typically needed at your Colorado clinic for 2 and 3 millimeter translations, both directions, respectively at C2-3? If you're talking about type 3A and type 3B craniocervical instability, then probably just 1 or 2. Again, don't know your clinical information, but at least that gives me some way to opine as to what most patients would need who have that problem. I've seen a patient with Groves whose thyroid labs improve, or with Graves' disease, whose thyroid labs improved after Prolotherapy to the lower neck. Have you seen anything like this? I have not. How far between PICL treatments do you need to wait for another one? Yeah, it's usually, PICL treatments are usually every 3 to 4 months. We do that because we see some patients that even take longer and put more time. But for most patients, we're checking to see if they've improved at around that 3-month mark. And then if they've improved at that 3-month mark, we're approving one, and they're getting that at maybe, let's say, 4 months to 5 months. But I would say 3 to 4 months is an appropriate amount of time between PICL procedures. I had flexion extension MRI and side tilt X-ray. That good enough to help with diagnosis? I think what you're referring to on the X-ray side is an open mouth lateral bending X-ray. Now, if the open mouth lateral bending X-ray gets maximum lateral bending at around 45 degrees, and if the head doesn't rotate during the open mouth, and they keep the C1, C2 joint in plane with the ability to see the corner at C1, C2, then that would be good enough to get the diagnosis. Now, obviously, there's a couple ifs in there because we've had some success in X-ray centers trying to replicate that open mouth view that's commonly obtained in a DMX, but not perfect success. So that's important. In fact, I just saw several open mouth view X-rays that were poorly done, and that is what that is, right? I can't change that. Do you have a favorite orthospinology chiropractor in the U.S. that you recommend? I do not. Have you seen patients with hEDS with a DMX findings that indicate that PICL isn't needed? Maybe they only need posterior PRP. Sure. Yeah. I mean, if that particular patient only has a type 3A, for example, or doesn't have any of the other types of CCI, then they might only need posterior PRP. Brett, I recently had Prolo done for CCI along with the vagus nerve hydrodissection immediately after the procedure, and for about 24 hours. My POT symptoms completely went away. Once the stiffness wore off, the POTS came back even stronger. Is that temporary relief a positive sign that the treatment is addressing the instability of nerve involvement? And is this a pattern you see in patients who end up improving continued treatment? Well, Brett, there's a lot I don't know here, but I think it'd be illustrative to point out what I don't know so that patients understand all the things that you need to get to answer a question like this, right? So the first important component here that I don't know is what is the craniocervical instability type specifically that you have? Is it a type 1A, 1C, 2A, 2B, 3A, 3B? I don't know that, so hard to answer this particular question. I also don't know what kind of prolotherapy you had done. Was it simple blind prolo? Was it ultrasound guided prolo? Were they trying to get into the facet joints with fluoroscopy and C-arm, with C-arm fluoroscopy and with contrast confirmation? What specific areas in the neck did they inject? What specific areas did they stay away from? Specifically, how was the hydrodissection done under ultrasound guidance, blind, etc.? Add to that what was specifically injected: D5W, platelet lysate, PRP. So there's, as you can see, there's an immense amount of information I don't know here, so I can't answer this question. But it's important to point out for patients that that's the minimum kind of information as a patient that you would need to know to sign up for one of those treatments. So incredibly important to get all of that dialed in, and as a patient understand that there's a massive difference between what's called prolotherapy and vagus nerve hydrodissection at one site and prolotherapy and vagus nerve hydrodissection at another clinic. So very important stuff there. Blessed, what's the biggest tell all that a person has CCI and is highly likely causing their symptoms? I don't know that there is a big tell-all. I would say that it's better to say upper cervical symptoms. So upper cervical symptoms are patients who have neck pain, headaches, dizziness. No one seems to know what's causing those things. And that it's a little bit more towards the CCI side if activity tends to make those things worse. And then if a hands-on exam points in the direction for that particular patient of having an upper cervical problem, and then next, if movement-based imaging then shows upper cervical instability. So as you can see, Blessed, there's a lot of information that has to be gathered there. There's certainly some pathognomonic findings that are going to make you think the upper cervical spine. And then you've got to figure out, as the doctor, is it Craniocervical syndrome or craniocervical instability? Sid, if someone has a DMX and upright MRI with flexion extension views, will there be any additional knowledge to be gained from a supine MRI for cervical instability? That for most patients, that would be very unlikely to gain additional information there. Now, sometimes you might be in a situation where the upright MRI was very, very poor quality. And if that's the case, then you may need to get a supine MRI. The problem with upright MRI is that it tends to be poorer quality than supine MRI, but usually you can see what you need to see. Dr. Silva in Washington State, I believe, was trained by you. Michelle, not for these issues, no. Dr. Silva did not receive any upper cervical training at our clinic. Dr. Silva did not receive any training in craniocervical instability at our clinic. So he did receive general spine training at our clinic. He did receive peripheral joint training at our clinic, but not for upper cervical issues. Ellie, good morning, Dr. Centeno. Looking forward to our teleconference. Is it only determined if CCI at the teleconference and then recommended an in-house exam, or if an in-house exam is then scheduled, is there any treatment for that visit? Yeah, Ellie, so it's pretty common for the telemedicine to yield a preliminary diagnosis and then for us to schedule treatment. Now, if we're fairly certain that we know what's going on at that point, then we schedule the person to come out for a hands-on exam and treatment at the same time. And 95 to 98% of the time, we're right that that person does have an upper cervical issue that's worthy of, let's say, getting a PICL treatment. So realize that, yes, we often schedule treatment at the same time as that hands-on exam because we've done quite a bit of due diligence to try to make sure that that person has symptomatic craniocervical instability before they make the trip out to our clinic. Let's see here. Julie, good morning and happy holidays. Question: I have developed BVD, convergence to saccades. Since diagnosis of CCI, it'd be difficult to correct these until the instability has been corrected. I've noticed some improvements. Yeah, so if you're working with a vision therapy optometrist, I'd continue that work, but generally those things aren't going to get better until the craniocervical instability component is corrected. Let's see, got a long one here. I'm going to try to summarize this. Hi, Doc. Thank you for your live session. My symptoms started with dizziness and pressure on my occipital area. Used to go to ER every other day. Had neck stiffness, did surgery, C4 through 6, ACDF. The surgery helped me with my pain in the hands, but it didn't fix any head pressure, light sensitivity, and eye pressure. I've had the test done. I got checked out, a cerebral spinal fluid leak, brain MRI, carotid vein checked out, upright MRI, DMX checked out, venous spinal fluid, as well as nothing. Yeah, so Nino, I think you bring up a common set of issues, and that is that patients also or often have more than one thing going on in their neck. So if we look at that, it's pretty common to have lower cervical problems, for example, get lower cervical fusion surgery, and then the upper cervical spine either gets worse or doesn't get better because it was never treated. That's pretty common. We see that quite a bit. So at the end of the day, the question would be, is it a craniocervical syndrome? So if you've ruled out craniocervical instability and there is no craniocervical instability, then the next thing to look for is craniocervical syndrome. Are those things coming from an upper cervical problem that doesn't involve instability? Now, I need to know more here. I need to look at the DMX and see what's on the DMX, look at all the imaging, etc. But that's generally the next set of steps for those patients. Type 2B, 3B, CCI, and I get symptoms when being upright, moving around, brain fog, dizziness. This is common with these types of CCI. Yes, all of those things are common in CCI. Follow-up on previous question, had DMX, but one of your PICL physicians said it was clean and without instability. He said heavy head is likely mild C2 multifidus atrophy, MRI, and poor DNF tolerance. Yeah, so that would be a craniocervical syndrome, which would mean that if you don't get better with conservative care, you would get specific upper cervical injections. So realize, again, we have two things here: craniocervical instability, which means you've got upper cervical problems, and those upper cervical problems are coming from instability in the upper neck, and craniocervical syndrome, which means you don't have instability, but the problems are still coming from the upper neck. Those are treated pretty similarly, other than, obviously, if you don't have the instability, you don't treat as many as the ligamentous components. So, for example, PICL wouldn't be a good next step, but you can get your ligaments treated in other areas posteriorly. And more importantly, you would focus on those upper cervical structures during treatment. For instance, the upper neck facet joints, the nerves that might be causing the symptoms. Okay, here. Blessed, can doing the motions for DMX make ligaments worse? Generally not. Blessed, I asked earlier about transferring care from the doctor. Just curious if I have to schedule another telemedicine. A lot of that would depend on the specific circumstances. So you would ask someone in our office to do that. I would look at the information to try to make sure I'm comfortable. And then if I'm comfortable, the transfer of care can happen. Sid, what do you envision the future of PICL and CCI treatment will be like? Yeah, I think the biggest changes going forward, now that we've kind of dialed in the procedure itself, would be more in terms of better injectates. For instance, supercells, cells that are genetically engineered for repair, for example. So those are really the areas where you would see improvements. I don't think we're going to see that much improvement in targeting. That took us about 10 years to figure out. It's one of the reasons why ePICL is so different than PICL. Is it possible we might come up with an even better way to do it than ePICL? That's physically or theoretically possible. I think it's unlikely, knowing what I know at this point, 10 years in on this procedure. Having a hard time finding someone to do DMX in my state. Do you have any resources? Yes, Michelle, we have a list of DMX providers. You can also get a DMX done in the clinic as well. So if you come out without a DMX, you're in a flexible slot. I don't do flex slots anymore, but that's Dr. Pitts and Dr. Schultz and Dr. Merkel do flex slots. That means that you would come out. We would have the ability to do either a PICL or an upper cervical injection without the PICL, and you would get the DMX done while you're in clinic, and then we would determine how to proceed from there. So those are different options. Curious, is PL with 12.5% dextrose the go-to solution for hEDS patients when simple dextrose is not strong enough? Why is dextrose more better than plain high-dose PRP or high dose, maybe PRP? Yeah, so my clinical experience for hEDS patients, the absolute best thing is bone marrow. Then it's Prolo or platelet lysate spiked Prolo. And then PRP seems to be the least effective of the bunch. Why is that? It's probably because of the inflammatory cascade causes a different mix of collagen to get laid down. That's probably more supportive for hEDS patients. That's my best educated guess. So BMC is the most inflammatory thing, then Prolo, then leukocyte poor PRP. Sid, when you refer a patient for lower neck disc bulge discectomy, when all their interventions have failed, what does that look like? If a disc replacement or ACDF, or is disc partially shaved? Yeah, so Sid, I often tell this to my patients. Regrettably, our surgical system and spine is a little messed up, in my opinion, meaning that at the end of the day, most patients just need a discectomy. That is taking off a little bit of the disc so it creates room for the nerve. Now, we don't see a lot of discectomies being done. Instead, we see a lot of ACDF type fusions being done. We see a lot of artificial discs being done. And frankly, in my opinion, that's more related to reimbursement than medicine, meaning that we don't have any data that a fusion or an artificial disc is any better than just doing a good old-fashioned discectomy, but they do pay more through insurance. So regrettably, I often tell patients it's very hard to find surgeons that'll just do a discectomy anymore. They all want to fuse or put artificial discs in. That's despite the fact that we don't have data that shows that those are any better than just doing a discectomy. So if it were me or my family, I would recommend finding a surgeon that'll do a discectomy over a fusion or an artificial disc. Have you ever heard of the link between pelvic congestion syndrome and CCI? I haven't, no. Casein, how do you treat CCS with injections? Yeah, casein, it's the same way we treat CCI with injections, other than we don't do the PICL procedure. So for example, it might be injecting the 0-1 facet joint, the 1-2 facet joint, the 2-3 facet joint, the greater occipital nerve, the lesser occipital nerve, the superficial cervical plexus, the vagus nerve, etc. Yes, Carol, I am sitting in a Whole Foods parking lot right now trying to get a 5G signal in my car because we don't have power at the house, haven't had now for several days. So hopefully they'll restore the power back sometime today, and I can start getting some work done that I need to get done. JS, how does craniocervical therapy help? What exactly does it do to improve neurosymptoms? You know, I don't think anyone knows the answer to that, JS, and certainly not myself. Who would be a top surgeon for discectomy? I don't think Dr. Henderson does routine discectomy so much anymore. His focus is going to be on upper cervical. And I could tell you local surgeons who do discectomies, but that's probably not going to help you. So again, you know, my sense is try to find a surgeon who does discectomy. Do you know about how long it takes before someone gets back to you from your office about an appointment? I sent a message a few days ago. Let's see, Michelle, I don't know, but if you're having issues, then just reach out to me directly on Reddit via private message. It's that RPICL sub, and you can reach out to me and I can try to assist you if you're having problems there. That's always good for me to know if there's a problem. Normally what it takes, though, just realize is we're gonna pre-screen everything first. So that means that they're going to gather all the information. They're going to gather all your imaging. They're going to have you fill out an online questionnaire, and then I'll review all of that and see if it looks that it's likely that you have craniocervical instability. And that's the first part of the evaluation, because we want to try to make sure that we've looked multiple times to ensure that we can help somebody before they come all the way out to Colorado. For everyone, stay away from a CCI con artist YouTuber who blindly does dry needling of suboccipital tendons to decrease overhang, also puts ridiculous head weights on patients. Yeah, I think what you're bringing up is that trigger point dry needling in general is a common thing, can be done at physical therapy offices these days. It's relatively cheap, 70, 80 bucks a visit. And curve restoration is also done at chiropractors who are certified to do curve restoration work. That's idealspine.com. You don't really need someone to do specific dry needling of tendons. You don't need head weights or anything like that. So realize that all of those same things can be replicated for very low cost, and usually locally. You don't need to travel someplace to get your suboccipital tendons dry needled or have someone put head weights on you. Has there been a biopsy that repaired ligaments to see what they look like? Yeah, that's never going to happen here, Cynthia. It would be impossible to get a biopsy in this area. Now, I can tell you that what can be biopsied with regard to, for example, other orthobiologic targets, for instance, a good one would be Achilles tendons have been biopsied. I don't know how they got the IRB approval for it, but they did, showing that PRP promoted repair. But as far as getting a ligament biopsy of a transverse ligament or an alar ligament, that's never going to happen, meaning that even in fusion cases, you're not actively visualizing those ligaments. And if you're actively visualizing those ligaments, something really bad has gone on. So just understanding how surgery works, in order to get access to those ligaments, you would put the patient at severe risk of life and limb. Do you treat a lot of C0C1 patients and find them to have good results? We do treat a lot of C0C1 patients, and they have very good results. Okay, guys, it looks like we are at the 1 hour mark, and I am still sitting in my car in a Whole Foods parking lot because I don't have power at my house, trying to make sure I get your questions answered. So I'm probably going to call it a day here. I want to thank you for joining in today. Great questions. Again, it's wonderful to see great questions because that's how we all learn. And I will probably be doing this next week, hopefully in my house with power and broadband internet. So, but if I don't see you before then, or don't talk to you before then, or don't private message you or email you or whatever, or post to your Reddit question, I wish everyone happy holidays, and I will probably see you before the new year. Thanks so much.